I'd like to thank the organizers for allowing me to present this topic. I have a passionate interest in Peyronie's disease, and my aim here is to advance the field. These are my disclosures, and I will state that there was no external funding for this research. As by definition, Peyronie's disease is an acquired penile deformity characterized by a fibrous plaque within the tunica albuginea, and it may be accompanied by any one of these 5 different presentations here. Mostly we know it by deformity or penile curvature. Importantly though, the prevalence of Peyronie's disease is approximately 4% of adult men in the United States. My outline of this presentation will be to follow the recent reviews on fibroproliferative diseases to provide a background, go through the pathogenesis of Peyronie's disease, look at different models that have been used, talk about our model and the future directions we should take. So in reviewing fibroproliferative diseases, which are quite common, you may have heard of them: pulmonary fibrosis, hepatic cirrhosis, cardiovascular disease, myelofibrosis, systemic sclerosis, Dupuytren's contracture, hypertrophic scars, keloids. Rarely is Peyronie's disease mentioned at all. As you know, it's an excessive accumulation of connective tissue and at the same time a tissue contraction that causes a deformity. The fibroproliferative process is a fibrosing process that disrupts normal organ function and development and may even lead to organ failure, and it can affect nearly all tissues in the body. Fibroproliferative diseases account for 40% of mortality in developed nations, and this is really quite important to recognize this and put this in any kind of grants. These are the major fibrotic signaling pathways, and in the center, if this will work, you can see the general regulator is the TGF-A pathway that sits at the yellow here, the cell membrane. It's important in inflammation, remodeling, and the actual fibrotic process. It works through the SMAD pathway and works on profibrotic genes that causes fibrosis to occur. It also has an influence on the hedgehog developmental pathway that causes this, and likewise on the Wnt pathway that can cause the same type. Interestingly, the integrins that exist on the cell membrane can be stimulated and engender the Rho-ROCK pathway. And this is an area of great interest now for many researchers. And our institution that looks at, my institution, when we look at pulmonary fibrosis, this is the new area of attack. Importantly, these pathways cross-communicate. There is a crosstalk between all of them. So if this is stimulated, this is what it causes the whole process to occur with fibroproliferative conditions. Now, Francois de Gigot de Peyronie was King Louis both 14th and 15th personal physician, and we all know that there's a better prognosis if a patient is young and has a small soft plaque versus those that are calcified. It's initiated by basically the deposition of fibrinogen, which is converted to fibrin and starts the whole process in the interlaminar space. The fibrin itself promotes the ingrowth of inflammatory cells, as listed here, cytokines, and also starts fibroblasts. Fibroblasts themselves proliferate and are attracted to trauma site by a number of different mediators. This is the model as the best we know it right now. Basically, there's an area of trauma, and this was initially put forth by Charlie Devine about 50 or 60 years ago, where microtrauma during sexual activity starts the whole process where there's a little bleeding within the interlaminar spaces of the tunica albuginea. Platelets are there. They release granules that start both the deposition of fibrin and fibronectin. This starts the inflammatory pathway, which causes macrophages to convert and work on fibroblasts, convert them to microfibroblasts. There's an imbalance here, and the extracellular modeling takes place where there's a deposition, and the whole fibrotic process ensues. This can, in some cases, actually calcify. Now, the models that have been presented in the past include cadaveric pericardium, surgical trauma, injection of fibrin, injection of TGF-beta, and also tunica albuginea allografts from rodents from one to the other. And this is just an example right here where the actual graft is placed, and you can see this is a thickened tunica albuginea with all the different presentations that we would expect. Therapies for Peyronie's disease you're all familiar with these. Most of them are anti-inflammatory, but the important thing to know, if we look at all the different guidelines from the different societies, that there's no benefit from these guidelines. We do use NSAIDs and PD5s when it comes to prevention of pain, but there's no evidence that curvature can be improved. All these other conditions have actually been negated. Unfortunately, one of my favorites was interferon 2B alpha. This is no longer commercially available. Collagenase is FDA approved and has shown benefit in men up to 30%. Traction devices, there's limited evidence, but there seems to be promise in this. And surgery, of course, is invasive, but it has potential AEs, but it can resolve all of the curvature deformities that are there. We talk about TGF-beta, it's been very popular. It's been implicated in many fibrotic conditions, as I mentioned before, pulmonary hepatic fibrosis and ad nauseum. There was a study done by SMSNA, took 30 patients, and 26 of these actually demonstrated increased TGF-beta present. There's a more recent study where myoblastic cell lines have been isolated, and with the idea of trying to inhibit TGF-beta and see if this would benefit. Although these studies are actually very interesting, show promise, none have led to an increase in effective treatment options. I'd like to mention when it comes to Peyronie's disease in research. This is an interesting publication done a few years ago, and it reviewed all the peer-reviewed Peyronie's disease publications from 2006 to 2018. The median number of yearly PD publications was 31. And from this group, there was about 427. The most frequent publications were in the Journal of Sexual Medicine, which had actually 25%, Urology, BGU International, and the Journal of Urology. Plaque excision and grafting was the most common topic, followed by pathophysiology and interlesional therapy. Now, interestingly enough, when it comes to the surgical subspecialties, urology has the least NIH funding, less than 2%, and only 15.1% of these articles, N equals 66, had any funding. 2.3% came from the NIH. In total, 4.1% of the articles were industry funded, and almost 2/3 of these came from the makers of Xiaflex or the manufacturer. The remaining articles were all self-funded. There were 15 and 24 unique authors. Of these, just 13 received direct industry funds, totaling $718,000 over this time period. So most Peyronie's disease research is self-funded, and only a small percentage actually originate from the NIH or from industry. So going to an area of study, cancer animal models have been the focal point of in vivo experiments. And cancer research has been the forefront of advance when it comes to models to develop novel therapies. Our hope in this presentation and to stimulate our society is to emulate the advances in cancer research by developing novel therapies for Peyronie's disease and making progress in this area. So if we look back, animal models were used way back in BC by these Greek philosophers and the like, and we knew about 200 years ago that there are certain exogenous factors that can cause cancer. And if you remember from medical school, they talked about the chimney sweepers in England. They developed scrotal cancer with this. The first inbred mouse strain was in the early 1900s, and then cancer models started to develop. Most importantly, the cell line production, where these were established. Along these in the last 50 years were the first xenograft animal models, and then they described the first PDX models in the 1980s or so, and the gene-engineered mouse models were also developed. Unfortunately, it was only until 2016 that they started to look at the PDX models. The NIH was looking at cell line models and thought this is the way to go. So if you look at by knowing this, like 2016, that there's a different change, you can see that the actual, these are the number of peer-reviewed publications when it came to the xenograft model and it came to the genetically engineered models. And around this time, once in 2016 it changed, the number of publications when it came to animal models, patient-derived xenografts took off. And this has been the case. This has gone up tremendously over the last few years. And actually, if you go to the oncology sessions, about a third of the presentations now concentrate on patient-derived xenografts in animal models to learn things. Where does this go? If we look at the top here, this is the typical thing that we're working with. They basically obtain a malignant tissue and basically engraft this into these immunosuppressed or nude rats or mice, and they go through different generations. What's important about this is actually a cell that grows and the microenvironment is all intact. It's very different from the other models that we had before. And what I learned is that about 90% of the different immunotherapies and chemotherapies don't work or they become resistant during treatment. So what's been developed is these co-clinical trials more recently where the tumor is basically treated and also the animal, the immunosuppressed rat is also engrafted, and both are concurrently treated. So if resistance does develop, these can be analyzed both in the putative animal and in the human, and it can be changed over time. So this is basically, I guess, a rough decision of precision medicine that's ongoing. So I think this is very important when we look at these things. So when it comes to a Peyronie's patient-derived xenograft model steps, in our case, we took men with very severe Peyronie's disease, which were refractory to Xiaflex or not desiring to have intralesional therapy. They underwent surgical incision with partial excision and grafting and for the correction of their curvature. Any hardened areas of calcified area were basically excised because we can't put a suture through that, and adjoining to that area we took little segments. These were transported out of the OR and shortly after actually engrafted into our animals. These athymic or nude mice were anesthetized. We dissect the rat penis with magnification, and we put the grafts in and follow these. We close this area, and for 4 to 6 months, we follow these animals. So here's basically on the far left, you can see the actual human picture, the pseudoplast. We take these little segments and put this into the animal. And this is just a cartoon that demonstrates the plaque. This is the human plaque that's actually live at the time. We sew this in and we put actually a non-dissolvable identification suture to know where this is. And if you can look over here, this is a typical animal after a number of months after, and you can see the actual site of the placement of the graft. Our first 6 animals, we did have one sham, and I will state that I'm the one that put this graft in that fell off. The other residents that were involved put the other 4. We did have one. These are basically immunosuppressed rats. They're very likely to catch different conditions. One passed away. But our mean curvature was 37 degrees, and you can see this is the sham, and A and B is the actual one that has a typical curvature that we have. And here is a H&E stain of the plaque prior to implantation. It just basically shows a lot of some fibroblasts and myofibroblasts and a lot of cellular tissue. This is just a higher power of it. And also here's a cross section. This is after 5 months. We sacrificed this animal, and you can see on the far left the foreskin, the corpora, the urethra, and here's this area where the graft was placed. This is just a higher power showing the dense fibrosis on the far right. And this is 5 months later. And once again, you can see that we still have ongoing cellular nuclei of cells and also dense tissues. And these are trichrome stains that show increased amounts of collagen deposition and scarring that you would typically see with Peyronie's disease. We worked with Jennifer Gordetsky, who is a urologist that became a pathologist, and she's a supreme individual to read these things, and she gave this evaluation, which I'm glad to show. She's at Vanderbilt, to give her credit. There was no inflammatory response at this time. Very dense collagen, low cellularity, but the fibroblasts appear viable. There's no necrosis. The plaque is subcutaneous. It does not involve the urethra or the corpora. So this actually shows the durability of this model. These cells are still living after periods of time. So where do we go from here? Well, we all know that Peyronie's disease is both a physical and a psychological debilitating condition. There are limited effective non-invasive treatments. These PDX models have expanded and improved cancer research and outcomes. This is the first study to demonstrate a successful PDX Peyronie's animal model. Our next steps are to continue characterizing the current successful grafted nude rats and perform further human staining and consider more advanced pathway analysis. The idea is to increase, to demonstrate the effectiveness and reproducibility of this method. We hope to try novel therapies, and as I mentioned before, the ROROC inhibition pathway with or without collagenase. And since this is a new animal model of Peyronie's disease with the chance of making significant advancements in our field, we welcome any collaborators who wish to use this model as we continue further refinements. Thank you very much. Dr. Liu.
May I make a comment? First of all, a great job, Wen. One of the things that I think this is a good direction, and I think it may help us in the future about some novel treatment. But there's one thing I'd like you to look into in the future is that when we did this with the electron microscopy, one of the major problems with a Peyronie's plaque in human, when we did the operation, is the total broken down of elastic fibers and totally unorganized or disorganized collagen fibers. And because of all this disorganization, you lost the elasticity and plaque and also the curvature. So in your model, it would be nice, after you follow them for a number of months, just look at it with under electron microscopy, just see what kind of change happened within that explant or implant.
Thank you. It's very hard for me to hear because there's a lot of echo here, but maybe I need a hearing aid, I don't know. But okay, Larry, please.
No, Wayne, the audibility up there is terrible for some reason. I think Tom's comments were spot on because we have some wonderful drug here, collagenase. It makes sense. And yet we're not seeing dramatic improvements routinely with this because I think of residual scar tissue, disorganized tissue, which just doesn't expand, so it's not normal afterwards. I applaud you in actually pursuing this type of a model because it looks like then you could potentially offer different types of treatment to this population. Do you think that having just a 2 or 3 millimeter piece of tissue is going to be enough to be able to help us really understand what is going on and whether there's really a meaningful response, whatever we use to try to initiate a change?
I do. I think that's enough, and we don't necessarily have to put it in the tunica albuginea in the future. We can put it in other parts of the body as they've done in the oncology field. But what's here is you can have the same animals, multiple of them, and you can try different treatments at different doses and learn something very quickly so we can make more advances. We can use combination therapies. We just mentioned the ROROC pathway, which is something of great interest in fibroproliferative diseases. We can try different agents at different times, and we may actually provide a preventative measure. When patients come in early, we can potentially treat these people or people who suffer from this at an earlier stage and not develop a severeness. All of this is open, but I think it basically sounds a foundation that we can move ahead and make great advances in Peyronie's disease.
One follow-up question. Do you think it would make a difference if we could possibly ever get it, early stage Peyronie's, which might be more hypercellular and more active, so to speak, than the stable phase Peyronie's, which is clearly hypocellular, hypervascular?
I think you're absolutely right, yeah, but we don't use the calcified or the area that is so hardened. We try to take the adjoining area that probably has some active cells. But by your means, of course, if we have a man coming in who has early treatment, we would obtain that and study this. But these are animals that are around for 6 months, so you can do these, and they've got thousands of these animals in different companies right now that are actually growing for cancer treatments. So this is basically the concept, yes, and you can do different stages and learn these things. But this is just the beginning. Okay, thank you.